Good evening, everyone. Today we are here to see the anatomy and physiology of esophagus along with some benign disorders of the esophagus. Eventually, we will be having other classes on the malignant and benign disorders of the esophagus as well. So let us start with today's class. Over to you, Samir.
Mm. Hello, ma'am, can you hear me?
Yes, Samir,
Yeah.
you
Okay.
can hear.
Okay. Okay. Good evening, everyone. I'll be uh, presenting my class on esophagus anatomy and benign disorders. So we'll be dealing into embryology, anatomy, physiology, diverticula, motility disorders, and then Dr. Likith will take over for GERT. So, as for embryology, during the week 4, the foregut will develop into a small diverticulum on its ventral surface, adjacent to the pharyngeal gut. This tracheobronchial diverticulum will then subsequently elongate and separate from the dorsal foregut through the formation of esophageotracheal septum to become the primitive respiratory tract. Foregut will then rapidly elongate with the craniocaudal growth of the embryonic body. In the seventh and eighth week, the luminal epithelium will proliferate and almost completely occlude the foregut, with only residual channel persisting. By week 10, the new vacuoles will appear in the luminal cells of the foregut and then join to form a single esophageal lumen with superficial layers of ciliated epithelial cells. At about fourth month, the stratified squamous epithelium will begin to replace the ciliated epithelium, and only residual islands of ciliated epithelium will be present at proximal and the distal end of esophagus. During the week 6 of gestation, the circular muscle coat and ganglion cells of the myenteric plexus will form, and during week 7, blood vessels will enter the submucosa. So as we know, the gut development takes place in four major patterned axes, which is antero-posterior, dorsoventral, left to right, and craniocaudal. Each axis development will be based on epithelial mesenchymal interaction mediated by specific molecular pathway and also endodermal proteins. These factors will both change the esophageal environment and making it more permissible for neural cells to enter and migrate within the esophagus. The smooth muscle layer, which is the lower esophageal lower esophagus, where the lower esophageal sphincter is formed, is derived from the mesenchyme of the somites, and the striated muscles will forming the muscularis propria and the upper part of the esophagus are derived from the branchial arches 4, 5, and 6. The middle third of the esophagus is a mixture of both smooth and skeletal muscles. The proportion is controversial, and the two muscles actually arise from two distinct differentiating pathways. Then at about week 4, as I said before, the neural crystals will enter the foregut and migrate rostrocaudally and to the terminal hindgut by week 7. Then interstitial cells of Cahal, which is the pacemaker of esophagus, will emerge from the gut mesenchyme at about week 9, and they will they'll form the network surrounding the myenteric plexus. Any changes in the coordinated process could result in clinical morbidities such as Hirschsprung disease, where the hindgut is devoid of enteric neurons and glial cells. At the second trimester, the lower esophageal sphincter is immature, resulting in frequent regurgitation of food. It approaches the pressure of the adult at about 3 to 6 weeks of age. Uh, the separation of the developing trachea and esophagus is tightly regulated in the developing embryo, and failure of any will lead to the formation of esophageal atresia or tracheoesophageal fistula. The most common form of this is where there will be an upper esophageal segment of esophagus ending in blind pouch, and the lower segment will just originate from the bifurcation of the trachea. The two segments may either be connected by a solid cord or may not. The classification system of tracheoesophageal fistula was made by Dr. Gross in 1953, which still remains predominant system in place today. By far, the most common is the type C, where there will be esophageal atresia with distal tracheoesophageal fistula, which is seen it in about 85% of the patients. Less commonly seen and which are more surgically challenging are which include type A and type B, where there will be long gap defects from the because of a large tissue deficit between proximal and distal ends. Still rarer types are type D and type E, which is also known as type H, where there is actually no atresia of the esophagus.
Samir, 1 second.
Yes,
Sir
ma'am.
Niharika ma'am has joined. Um, Good evening, ma'am. Hello. Okay, okay, Samir, you continue.
Okay. Um, for the diagnosis of tracheoesophageal fistula, it is actually a combination of polyhydramnios and a small or absent stomach bubble on the antenatal ultrasound, which may indicate towards the diagnosis of esophageal atresia. There can also be other anomalies associated with like vector anomalies, which are detected antenatally, such as cardiac anomalies, genitourinary, which also raise a suspicion of esophageal atresia. Postnatally, if at all patients babies born without antenatal detection usually will present within first few hours or days of life with excess saliva, coughing and gagging during feeds. Occasionally, they will also have apneic episodes due to aspiration of milk. Diagnosis is confirmed or ruled out by passage of nasogastric tube, and if this coils in a dilated proximal pouch on a chest X-ray, the diagnosis is confirmed. Prevalence of this tracheoesophageal fistula is about 1 in 3,500 live births, and most common will be the type C1. So, vectoral anomaly will include vertebral anomalies, anal atresia, cardiac defect, most commonly VSD, tracheoesophageal fistula, renal or radial anomalies, and this will raise a suspicion about tracheoesophageal fistula. For the repair, mostly the patients will be placed in a general anesthesia position on their left side. A posterolateral thoracotomy incision will be made with the and the muscle layers will be split so that we'll approach a muscle sparing technique at the fourth intercostal space mostly with the extrapleural approach. After gently retracting the right lung, uh, the lower pouch of the tracheoesophageal fistula is identified, and the transfixion suture is placed across the tracheoesophageal fistula close to the trachea, which is then divided distally. A replogal tube is advanced from the mouth, and an incision is made over the tip, and then the distal esophagus is mobilized. End-to-end anastomosis is made, and then we have to take care that we have to include both mucosal and muscle layers. As of for the long gap esophageal atresia, gastrostomy formation and a gap assessment is performed at birth to establish feeds and assess the degree of tissue deficit. Occasionally, the gap cannot be breached, as in type of C or type D. In these cases, we have to go for esophageal lengthening procedures such as tissue flaps, spiral myotomy, or gastric division. Ma'am, should I continue?
Anyone having any doubts in tracheoesophageal fistula? Niharika ma'am, anything else to be added in this topic?
Uh, am I audible? Hi.
Yes, ma'am. Yes, you are. Hello, ma'am.
Yeah, yeah. I think he's presenting quite well. I think he should continue.
Okay, ma'am. Ma'am, any questions or anything to add, you can stop in between any time.
Sure, no problem.
Yes. Okay, Samir, you can continue.
Basically, esophagus connects the pharynx to the stomach. It will be it beginning in the neck at the junction of pharyngo-esophageal junction, C5, 6, C6 vertebra interspace at the inferior border of cricoid cartilage. The esophagus will descend anteriorly to the vertebral column through the superior and posterior mediastinum. After traversing the diaphragm at the diaphragmatic hiatus, T10 vertebral level, the esophagus extends through the gastroesophageal junction and ends at the orifice of the cardia of the stomach. Here, the esophagus is pushed anteriorly to accommodate the thoracic aorta. Topographically, the esophagus can be divided into cervical, thoracic, and abdominal esophagus. Cervical esophagus will extend from pharyngo-esophageal junction to the suprasternal notch and it extends about 4 to 5 centimeters. At this level, the esophagus is bordered anteriorly by the trachea, posteriorly by the vertebral column, and laterally by the carotid sheaths and the thyroid gland. Thoracic esophagus extends from suprasternal notch to the diaphragmatic hiatus, passing posterior to the trachea, the tracheal bifurcation, left main stem bronchus. The esophagus lies posterior and to the right of the aortic arch at T4 vertebral level. From the level of T8 till the diaphragmatic hiatus, the esophagus will lie anterior to the aorta. Abdominal esophagus extends from diaphragmatic hiatus to the orifice of the cardia of stomach. It will form a truncated cone kind of a structure about 1 centimeter long. The base of esophagus transitions smoothly into the cardiac orifice of the stomach, and the abdominal esophagus will lie in posterior surface of the in relation to the posterior surface of the left lobe of liver. As of for the inlet, cricopharyngeus muscle forms the narrowest part of the gastrointestinal tract and constitutes the uppermost constriction of the esophagus. It is the principal component of the upper esophageal sphincter, a high-pressure functional zone formed by the complex muscles extending from the larynx to the posterior pharynx. It will include the superior and middle pharyngeal constrictors and the inferior pharyngeal constrictor, which is composed of thyropharyngeus and the cricopharyngeus muscle. The cricopharyngeus generates the upper esophageal sphincter pressure and acts as a transition point for circular esophageal muscles and coordinate swallowing. At this junction, the oblique thyropharyngeal fibers and the transverse cricopharyngeal fibers will create the Killian's triangle, the site of Jankus diverticulum. The mid-esophageal constriction located about at the level of T4 occurs where the left main bronchus aorta crosses the esophagus approximately 15 to 17 mm. The lower esophageal sphincter is another high pressure functional zone at the gastroesophageal junction, which comprises of two components, intrinsic and extrinsic. Intrinsic component is smooth muscle component and extrinsic component is diaphragmatic component. This is the reason why there is a like it prevents gastroesophageal reflux despite the presence of a discrete anatomical sphincter. Esophageal arterial supply is rich and it is segmental. Branches of inferior thyroid artery, as you can see the yellow highlight, supplies to the supplies arterial supply to the upper esophageal sphincter and cervical esophagus. The paired aortic esophageal arteries or terminal branches of the bronchial artery will supply the thoracic esophagus, and the left gastric artery and a branch of left phrenic artery will supply the lower esophageal sphincter and the most distal segment of the esophagus. There can be variation which is denoted over here where esophageal branches can originate from left inferior phrenic artery or directly from the celiac trunk, and branches from abdominal esophagus may also come from splenic or short gastric arteries. This is the because of the copious blood supply and network of potentially anastomotic vessels, explain the rarity of esophageal infarction. Similar to arterial supply, even the venous drainage is also segmental. From the dense submucosal plexus, the venous blood will drain into the superior vena cava. The veins of proximal and distal esophagus drains into the azygous system. Collaterals of left gastric vein and a branch of the portal vein. Um, the branch of portal vein will receive venous drainage from mid-esophagus. Submucosal connections between portal and systemic venous systems in the distal esophagus forms the um, esophageal varices in portal hypertension. These submucosal varices are the source of major gastrointestinal hemorrhage which occurs in patients with cirrhosis. As of for the mm, nerves of esophagus, cervical sympathetic superior ganglion extending from the esophagus to thorax will terminate in the stellate ganglion. Thoracic sympathetic from the stellate ganglion to the anterior and posterior esophagus. It will supply these supplied by the lesser splanchnic nerves to the distal esophagus. Vagus nerve will give the parasympathetic fibers and supply via recurrent laryngeal nerve and superior laryngeal nerve. Superior will further divide into external and internal laryngeal and supply the larynx and the inferior pharyngeal constrictors. This is the reason why if there is a damage to recurrent laryngeal nerve or superior laryngeal nerve, it can cause upper esophageal sphincter dysfunction. Vagus nerve will further supply the thoracic esophagus and both the sympathetic and parasympathetic and form the network plexus, the Orbeck and Meissner's plexus. Orbeck plexus regulates contraction from the outer muscle layers, where the Meissner's plexus will regulate from the peristaltic contraction from the muscularis mucosa. Vagal afferent merging from the esophageal smooth muscles are sensitive to both mechanical distension and they have this afferents with receptive fields which are sensitive to chemical, thermal, mechanical and interluminal stimuli. So as such, the vagal afferents do not play a direct role in visceral pain transmission, but because they have mechanoreceptors, they can also transduce pressure into painful sensation. Finally, the lymphatic drainage. Lymphatic channels will begin from the esophageal tissue as a space of network endothelial channels or as blind endothelial circulations. Lymph capillaries will drain into the collecting lymph channels that continue through the esophageal muscular coat and are distributed parallel to the long axis of the esophagus. So lymphatics from the proximal one third of the esophagus drain into the deep cervical nodes and subsequently into the thoracic duct. The lymphatics from the middle third esophagus and the superior posterior mediastinal nodes, um, the lymphatics from the distal third will drain into the gastric and the celiac lymph nodes. The bidirectional lymph flow of this region is responsible for the spread of malignancy from lower esophagus to the upper esophagus. Vascular and rich lymphatics make esophagus a durable organ, and but at the same time they create oncological challenges. Ma'am, should I continue?
Yes.
Yeah. Please continue. Please continue.
Okay. So now we go into the musculature of esophagus. The muscular coat will consist of external layer of longitudinal fibers and the internal layer of circular fibers. They are arranged in three fasciculi. The ventral fasciculi is attached to the vertical ridge of the posterior surface of the cricoid cartilage, uh, which I have denoted in this green marking over here. And then the two lateral fasciculi will continue with the muscular fibers of the pharynx. The circular muscles provide the sequential peristaltic contraction, which will propel the food towards the stomach, and the circular fibers are continuous with the inferior constrictor of the hypopharynx. They will run transverse at the cranial and caudal regions of the esophagus, but oblique in the body of the esophagus. Below the diaphragm, The internal circular muscles will thicken and fibers become semicircular, and they will get interconnected, and this will form the intrinsic component of the lower esophageal sphincter. There are also accessory bands and muscles which connect the esophagus to the left pleura, to the root of the left bronchus, and also to the posterior part of the pericardium. The muscle fibers in the cranial part of the esophagus are red and consist chiefly of striated muscles. Intermediate part is mixed, and the lower part, with rare exception, contains only smooth muscles. This is the pharyngo-esophageal junction, where we can see the upper esophageal sphincter, which is a musculo-cartilaginous structure composed of the posterior surface of the thyroid and cricoid cartilage, hyoid bone, and three muscles. Those three muscles are cricopharyngeus, thyropharyngeus, and the cranial cervical esophagus. Thyropharyngeus muscles is obliquely oriented, while the cricopharyngeus is transversely oriented. As I have mentioned earlier, this is the zone of sparse muscular fibers, which I
I
have
mean, if you
denoted
have a
in.
pointer, point out to the muscles that you're
Uh,
talking about
yes,
because it's
ma'am.
too small to be seen.
The um, yeah. Is it now better, ma'am?
No, like instead of zooming it, if you have a pointer, point out just directly to the muscle,
Um,
if you can.
Pointer is not coming. The violet one, which I have denoted, as we can see, is it better,
Yeah,
ma'am?
yeah. Okay, fine. Continue,
Hmm.
continue.
Yeah. The this one. Okay. Zone of sparse muscle fibers. This is the reason, this is the area of Killian's triangle wherein the juncus diverticulum might emerge, and cricopharyngeus muscle is attached to the is a striated muscles to the cricoid cartilage. It forms a C-shaped muscular band which provides maximum tension during the in the anterior posterior direction. It will extend caudally, and it will blend with the circular muscles of the cervical esophagus. The muscle fibers are arranged in two layers, as I have mentioned. The longitudinal arranged fibers and the internal layer of circular transversely arranged fibers. In over here, as we can see, there is a the window cut in longitudinal muscle layer, which expose the circular muscle layer at the lower end of the picture. Any inability of the sphincter to open, or if there is any discoordination from the timing between the opening of the upper esophageal sphincter and the pharyngeal with the pharyngeal push, will cause the oropharyngeal dysphagia. As of for the lower esophageal sphincter, it is a high pressure zone located where the esophagus will merge into the stomach. Lower esophageal sphincter is a functional unit of composing of intrinsic and extrinsic component. Extrinsic component is the diaphragm itself, and the intrinsic extrinsic component of the lower esophageal sphincter is composed of the diaphragm, which forms the esophageal hiatus, and it represents a channel through which esophagus is entering into the abdomen. The lower esophageal sphincter, presumably determined by the changes in esophageal mucosal color, which we can see over here, which is denoted by the Z line. This is the one which we see in see on endoscopy. So endoscopic imaging. This is the upper esophageal sphincter, tubular structure of the esophagus. This is the Z line and the lower esophageal sphincter. I'll continue. Oh,
Yes, Samir, continue.
okay. For the diaphragmatic opening and hiatus, several important structures cross the diaphragm. The inferior vena cava at T8 enters the chest through the opening in the central tendon, and it is accompanied by the small branches of the right phrenic nerve. The aorta with the thoracic duct will at the T12 level will traverse through the diaphragm through the aortic hiatus between the diaphragmatic crura. The esophagus with both the vagus nerve at T10 level will traverse the diaphragm through the esophageal hiatus. The yeah, there is a ligament which is um, the esophageal hiatus will is a slit-like opening in the diaphragm, and it is formed by the thickened bundles, as we can see over here. Okay, okay, zoom it. So the one over here, esophagus, there are two bundles of the central tendon which are thickened, and then the undersurface of the diaphragm is covered by the thin endo-abdominal fascia. This forms the phreno-esophageal ligament at the hiatus. The ligament is a fibrotic sheath which will then insert into the adventitia of the distal esophagus. Finally, the histopathology. Um, the wall of the esophagus will consist of four layers: mucosa, submucosa, muscularis propria, and adventitia. Unlike other areas of the gastrointestinal tract, esophagus does not have a distinct serosal covering. This allows esophageal tumors to spread more easily and makes them harder to treat surgically. Missing serosal layer also makes the luminal disruptions more challenging to repair. So mucous membrane will contain the non-keratinized squamous epithelium, which covers the entire surface of the esophagus except for the lower esophageal sphincter, where the squamous and columnar epithelium may coexist. Mucosal membrane is composed of stratum basale, which contains basophilic cells, which divide and replenish the stratum intermedium and stratum superficialis. Then we have the lamina propria, which is a thin layer of connective tissue. Muscularis mucosa, which is longitudinally and irregularly arranged smooth muscle fibers, and it will extend throughout the entire esophagus and continues with the gastrointestinal tract. Submucosa will contain connective tissue as well as lymphocytes and nerve cells, which are the Meissner's plexus. Esophageal glands are small racemose glands which have acini arranged like a grapes on a stem, and muscularis propria is responsible for the motor function. Finally, the adventitia, which is the external fibrous layer which covers the esophagus, connecting it with the neighboring structures. It is composed of loose connective tissue and has vessels, lymphatic channels, and nerve fibers. Ma'am, I'll continue. Hello.
Samir, continue. Anybody has any doubts or questions still here?
No, ma'am.
Okay. Samir, you can continue.
We'll dive into the diverticula. According to studies, it is now well established that most of the diverticula are either a result of primary motor disturbances or a abnormality of upper esophageal sphincter or lower esophageal sphincter. Zenkus is the most common esophageal diverticulum found today. It is usually manifested in older patients and seen at about seventh decade of life, and has been postulated to be a result of loss of tissue elasticity. As we have seen earlier, it is specifically found herniating from the Killian's triangle between the oblique fibers of the thyropharyngeus and the horizontal fibers of the cricopharyngeus. As the diaphragm diverticulum will enlarge, the mucosal and submucosal layers will then further dissect down to the esophagus into the superior mediastinum, posteriorly along the prevertebral space. Patients will initially be asymptomatic and they will complain of sticky sensation in the throat, halitosis, voice changes. If neglected, later signs in elderly patients can lead to aspiration. There is a limited role of endoscopy or manometry. Esophagram, as we can see over here, shows a Jenkins diverticulum. As of for treatment, for open repair, resection or surgical fixation of the diverticulum can be done, which is diverticulotomy or diverticulopexy, either by can be performed through an incision through the left side of the neck. For now, the gold standard of treatment is endoscopic Dolman's procedure, which has become more popular. It is the division of the common wall between the esophagus and diverticulum using a laser electrocautery or a stapler device. The esophagus and diverticulum will form a common channel. As you can see over here, this is the Z poem, wherein under general anesthesia with the endotracheal intubation, the endoscope will be positioned under direct vision to expose the diverticular septum, and initially at a just 3 centimeters proximal to the septum, the incision will be made and a submucosal tunnel will be performed, following which the division of septum between the esophagus and the diverticulum is done. After the completion of that, the cricopharyngeal muscle myotomy, the mucosa will be approximated using endoscopic clips, and this has shortened the hospital stay to about 1 day, and the next day a patient can be started on diet.
Any inputs from Niharika? Sorry, madam?
No, sir, nothing. I think he is doing
Okay,
quite well. Yeah.
okay, ma'am. No, regarding the endoscopic procedures.
No, he's done
Hmm.
the Z poem well. Yeah. I'm saying
Okay,
not that I
okay,
perform one, but yeah, I think he has laid
yeah,
down the steps very brightly.
okay, ma'am. Okay.
Sure.
Uh, for midesophageal diverticular, these are actually the etiology is due to the infections, mostly due to histoplasmosis, resulting in a fibrosing mediastinitis. Inflammation of the lymph node will exert a traction on the wall of the esophagus, and it leads to the formation of a true diverticulum in the mid esophagus. Uh, this is actually a diagnosis during like some other to like during a workup of some other complaint. The patients are incidentally found to have mid-esophageal diverticula. Esophagram, as we can see over here, shows a mid-esophageal diverticula. Um, um, Similarly, like endoscopy and manometry is a must to rule out any mucosal abnormalities, including malignancy that may be hidden in the sac itself. In addition, endoscopy will also identify if at all there is a fistula, and manometric studies should be taken to rule out any primary motor disorder. Treatment: if patients are symptomatic, diverticuloplexy is performed in patients who are symptomatic.
Any studies or any statistics on how many patients with these diverticulars have actually have motility disorder? If you can add that, because see, where will you get diverticular? You will get it on only high pressure zones, right? So there has
Yes,
to
ma'am.
be some associated motility disorder, as you rightly pointed out. So if you can get some statistics as to how many of these diverticular are associated with motility disorder, that will be great.
So my question will be, if there is motility disorder, then how will it change the management? Because you
It will
said,
change. Yeah, I mean, say if there is
Samir, I'm
achalasia.
asking.
Okay, okay, sorry.
Yeah, you can clarify after that. So I just wanted to ask
Yeah,
Samir
yeah,
regarding
sure,
that.
sure.
Samir,
Yes, sir. Sir, if at all there is a
so
motility disorder, we have to treat it first because
Yeah.
like,
like eclampsia or because it is a mid-esophageal diverticulum, most likely eclampsia or will be there.
Achalasia
correct,
will
correct.
usually cause lower
And
esophageal, but yeah, I mean, say there could be a distal esophageal spasm or
ataraxia.
hypercontractile esophagus or some motility disorder. So that would be the cause for all these diverticula. I mean, say you have seen it even in colon. There's high pressure zones, and even in Zenker's. Everywhere where there's motility and there's muscle and there's diverticulum, there has to be some high pressure zone for the diverticular to form. So yeah. So most
So
of the
apart
times,
from
yeah,
apart from
sorry.
this, like achalasia, then only there is endoscopic or surgical intervention. For rest of
Yeah.
it, it is what, Botox, ma'am, or tablets. If it is distal esophageal spasm or
For distal esophageal spasm also, we do a little
dilatation.
higher for during poem. The myotomy is little longer for a distal
Okay,
esophageal
okay,
spasm. Yeah,
okay.
yeah.
Fine, Samir.
Yeah,
So you didn't answer madam's question.
which one's the statistics, sir? Or
Yeah, I think statistics would be good, like just to know how many of these diverticular are associated with motility disorder. I think that you can take that as a question probably and
yes, yes, ma'am. Yes.
just see how many of them are associated with motility.
Okay, continue.
Uh, yeah. Then we have this epiphrenic diverticula, which are found adjacent to the diaphragm in the distal third of esophagus, within about 10 centimeters of gastroesophageal junction. These are often associated with distal esophageal spasm, eclampsia, or hypertensive lower esophageal sphincter disorders. In patients whom a motility abnormality cannot be identified, then we should probably think about congenital Ehlers-Danlos syndrome or traumatic cause. Symptoms of as for epiphrenic diverticula is concerned, they will have regurgitation, epigastric pain, anorexia, chronic weight loss, and halitosis. Uh, Treatment is again we have to like diagnose. We have to go for manometry, treat the underlying cause. This is a picture of epiphrenic diverticula. Coming to the physiology, esophageal mesenteric plexus contains of cell bodies of motor, sensory, and interneurons. There are two sets of populations of motor neurons. One set of motor neurons contains the choline transferase and substance P, and these are the cholinergic neurons. Cholinergic neurons are excitatory in nature and they contract the smooth muscles by releasing acetylcholine. The second set will have the second set of motor neurons is called non-adrenergic, non-cholinergic, and they release a neurotransmitter that is either that is adrenaline. These neurons have been shown to contain vasoactive intestinal peptide VIP and neuronal nitric oxide synthetase. These are nitrogen neurons, and the excitatory and inhibitory motor mesenteric neurons innervated by separate sets of preganglionic vagal fibers. The inhibitory vagal pathway will originate from the neurons located in the caudal region of dorsal motor nucleus, and these preganglionic neurons are cholinergic in nature and the synapse on the postganglionic nitrogen inhibitory neurons in the matrix plexus. While on the other hand, the excitatory ones, which are originating from the rostral part of the dorsal motor nucleus, they can be recognized as long latency vagal afferents, and these are also cholinergic in nature, and the synapse on the cholinergic excitatory part of the matrix plexus. So as we know, there are four phases of swallowing. The elevation of tongue, wherein food is taken into the mouth, and then a soft bolus is transported. There is posterior movement of the tongue. The tongue will move posteriorly to move the food bolus into the hypopharynx. At the same time, there will be elevation of the soft palate. Simultaneously, as the tongue moves, the food will move into the hypopharynx. Soft palate is elevated to close off the passage into the nasopharynx. And then the elevation of hyoid will happen, which will help to bring the epiglottis under the tongue, and hyoid bone will move anteriorly and upward. And then there will be elevation of larynx. The change in position of the hyoid elevate the larynx to open up the lateral laryngeal space, further facilitating the movement of the epiglottis under the tongue. Finally, tilting of the epiglottis will happen, and it will tilt back, covering the opening of the larynx to prevent aspiration. So there are in total primary, secondary, and tertiary is not used now. It was used like in the earlier year. Primary peristalsis is defined as reflex esophageal peristaltic contraction wave which is associated with swallowing. It will involve all the phases of swallowing reflex, including the oral phase, pharyngeal peristalsis, upper esophageal sphincter relaxation, esophageal peristalsis, and finally lower esophageal sphincter relaxation. Herein, mylohyoid muscle is the lead contraction, which it will lead the contractions lasting about 2 to 7 seconds. That will begin in the pharynx and move down to the esophagus at about 4 centimeter per second. And then we have the secondary peristalsis. If at all there are residual food in the esophagus, as seen in ineffective peristalsis, these are cleared using secondary peristalsis. Secondary peristalsis, which will not involve swallowing reflex fully. Instead, it is a reflux from the esophageal afferents, and peristaltic activity is restricted only to the esophagus. Tertiary was used no longer used now. It was used in past, where which were the contractions to lose their progressive character throughout the esophagus. But now it is proved that there is no tertiary peristalsis. Gravity plays a important role upon swallowing a bolus of liquid, or during the test, like we give barium to the patient. The bolus is pumped back to the tongue into the pharynx, and it will travel all the way to the esophagus into the stomach. It takes about 8 to 10 seconds from the initiation of the swallow to enter into the stomach. And then there is also deglutitive inhibition, which is a swallow evoked peristaltic contraction consisting of wave of inhibition followed by contraction. So this wave will precede the peristaltic contraction, hence it is called as deglutitive inhibition. This deglutitive inhibition is essential for drinking fluids when we take multiple swallows taken in rapid succession, and the esophageal body remains inhibited until the last series of swallow. Over here, as you can see in the image, it illustrates a normal esophageal peristalsis recorded by conventional esophageal manometry using pressure sensors at different levels. The three tracings are represent pressure recordings from 15 centimeter, 10 centimeter, and 5 centimeter from the lower esophageal sphincter over time. Following a swallow, as we can see, the first wave is seen at 15 centimeter, then at 10 centimeter and 5 centimeter. Each tracing shows a peaked pressure of about 50 mmHg, which is the adequate contractile strength, and there is a progressive time delay between the peaks, confirming a coordinated peristalsis rather than simultaneous contraction. This pattern represents the esophageal neuromuscular function, which is swallow-induced inhibition and following a propagated contraction wave, which is the physiological basis of normal esophageal transit. Uh, Can I continue?
Any questions from anyone till now? Any doubts?
Nothing, sir.
Okay.
Uh,
Ma'am, anything? Any inputs?
No, I think he's good to go.
Yeah. Okay. Continue. Samir.
Yes. Yes. So, esophageal motility disorders may be implicated as an explanation of dysphagia or non-cardiac chest pain after excluding all the esophageal structural lesions by endoscopy, with the caveat that eosinophilic esophagus has also been ruled out with histology. Esophageal motility disorders are rare, they are poorly understood, they occur in about 1 per 1 million population, and it is defined as manometric findings exceeding 2 standard deviations from normal. So for esophageal manometry, it is a test in which intraluminal pressure sensors, either water-based or solid state, are positioned axially within the esophagus to quantify the contractile characteristics of esophagus and segregate it into functional regions. The probe is inserted transnasally and connected to a recording unit via a hydraulic pump. In case of uh, and whereas conventional technique uses probes 3 to 8 pressure sensors spaced about 3 to 5 centimeter apart. Um, it uses about 36 solid state pressure sensors spaced about 1 centimeter intervals. The concept of esophageal manometry is used to use sufficient number of pressure sensors within the esophagus, such as the whole length of the esophagus can be um, measured by the conventional manometry. So for preparation, we have to verify that patient has fasted for 4 hours, and consent and verification of indication and contraindications are taken. We'll apply the topical anesthetic into the nostril, and HRM catheter calibration and placement should be done. We have to provide about 60 seconds for the adaptation period, and to confirm with 3 deep inspiration, and register 10 wet swallows using 5 ml of water in supine position, and then we have to perform the multiple swallow test. The secondary position will be upright, wherein we have to provide 60 seconds for the adaptation period again, and we have to confirm the catheter position with 3 deep inspiration. Similar wet swallows, but it will be 5 wet swallows using 5 ml water in upright position, and again the multiple. We have to do a rapid drink challenge, if appropriate, which is about 200 ml of water as fast as possible through a straw. So for a normal esophageal manometry, the high resolution esophageal manometry is displayed as a pressure topographic plot, as we can see over here, and the horizontal axis represents time, and vertical axis will represent the length of the esophagus, with the upper esophageal sphincter at the top, and lower the esophageal body in the middle, and lower esophageal sphincter at the um, lower esophageal sphincter or the G junction at the bottom. The pressure is depicted by the color coding. As you can see over here, the blue indicates that it is relaxed. Green to yellow indicates moderate pressure, and red indicates high pressure zones. A normal swallow will begin with brief relaxation of upper esophageal sphincter as a transient blue zone, and then it will be followed by a wave of deglutative inhibition, which precedes a coordinated peristaltic contraction traveling throughout the esophagus with increasing pressure. Time in the relaxation of lower esophageal sphincter is reflected by a fall in the pressure zones, as we can see, and then there will be the orderly progression of inhibition is followed by contraction, which is
I
called as
think in this image, the upper esophageal sphincter is missing.
ma'am.
Have you cut the sphincter? Because I don't see a relaxation in that. image
E
of the upper esophageal sphincter. Okay, no problem. Carry
yeah.
on.
Did you crop it? That is what madam is asking.
No,
You
sir.
only see the peristaltic wave, right? You on the
Yes, ma'am.
upper, like how you have in the lower, right? There is supposed to be a upper esophageal sphincter image also. I think you've cropped it quite a bit, so you're only seeing the peristaltic wave, and then you are seeing the lower esophageal sphincter. You have any other images? Then you will know what I'm talking about, probably. Yeah, in this one you have the upper esophageal. Can you see on this image the green upper top bar? That is the upper
Yes,
esophageal
ma'am. Yes.
sphincter, and then there is
Uh,
a once the swallow happens, then the pressure reduces. Yeah. So I think you've cropped that image. No problem.
okay. Uh, so, uh,
What are
so
these graphs called? They have a name of the person. It's called Klaus plots.
ma'am,
Klaus
okay.
plots. Yeah. Okay. Yeah. Carry on.
Yes, ma'am. This flowchart summarizes the Chicago classification version 4.0, which approaches the interpretation of high resolution esophageal manometry. It systematically categorizes motility disorders into esophageal gastric junction outflow disorders and disorders of peristalsis. After the 10 supine wet swallows to assess the median integrated relaxation pressure, an abnormal elevated integrated relaxation pressure will first we have to it will raise suspicion of esophageal gastro junction outflow obstruction, and peristalsis is then analyzed. So then, any disorders of esophageal junction outflow, we will categorize them as either achalasia type 1, 2, or 3, which will be seeing further. And um, then if at all the IRP is normal, then attention will shift to peristaltic disorders, wherein we can have either distal esophageal spasm, hypercontractile esophagus, ineffective esophageal motility, or a 100% failed peristalsis, which is absent contractility. The diagnostic criteria for type 1 achalasia cardia is elevated median IRP with 100% failed peristalsis. And type 2 is with the esophageal compression, wherein again the elevated median IRP will be more than 15 Hg with 100% failed peristalsis. And also there will be pan esophageal pressurization with more than 20% swallows. And type 3 will be there will be no normal peristalsis, and the distal contractile integral will be more than 450 mmHg. We'll see the all of them in detail. Um, for esophageal body, this distal like esophageal spasm, the diffuse esophageal spasm is thought to be a result of imbalance between the nitrogen inhibitory pathway and the cholinergic excitatory pathway, which we saw in physiology. So physiologically, there is a neuronal inhibitory gradient between the proximal and distal esophagus, and so that there will be a increased neuronal signal to move towards the distal esophagus and towards the lower esophageal sphincter. Um, if it has been shown that the patients who receive a nitric oxide scavenger, and like they will have abnormalities in timing of esophageal peristalsis, causing a simultaneous contraction in length along the length of muscles. So as we can see in this uh, image, the esophageal manometry, Uh, HRM is the gold standard for diagnosis of diffuse esophageal spasm. It is defined and it defines that this diffuse esophageal spasm, there will be premature contractions with the distal latency of less than 4.5 seconds in at least 20% of wet swallows. And the distal contractile, the integral will be more than 450 mmHg. Barium esophagram in a patient with distal esophageal spasm will show the corkscrew or rosary bead appearance of the esophagus. For management, as we have seen earlier, it is postulated that nitrogen neurons are the main cause. So, since nitric oxide is postulated to play a major role in pathogenesis of diffuse esophageal spasm, medication that enhance the levels of nitric oxide can be attempted, and there are both nitrites and phosphodiesterase 5 inhibitors, which are considered to decrease symptoms by increasing the availability of nitric oxide, allowing for an increased relaxation and decreased contraction. There are case reports and trials who have noted a decrease in lower esophageal sphincter pressure and peristaltic contraction amplitude. Also, by calcium channel blockers, they will inhibit the L-type channels, causing the relaxation of smooth muscle. If a patient has persistent symptoms, we can try an endoscopic treatments, which is interventions such as botulinum toxin injection. It will work by the release of acetylcholine in the neuromuscular junction, leading to muscle paralysis. It has been shown to reduce dysphagia score, stabilization of the um, um, decrease in lower esophageal sphincter pressure in patients with esophageal disorders. Finally, poem has been largely used for eclasia, but it has also been used in some cases of non-eclasia spastic disorders such as diffuse esophageal spasm. It has an effective rate of about 80%, and it is safe for spastic disorders with infrequent significant any adverse events. But all of these studies are actually retrospective, and there are no expert guidelines for the same. Surgical myotomy can also be another option for when medical therapy fails or there is no expertise to perform poem.
No, you're talking about achalasia, no?
No, sir, diffuse esophageal spasm.
Diffuse is okay, okay.
Yes. Sir, there is about 20 slides more, sir. Nutcracker esophagus and achalasia and duplication cyst.
Achalasia will go on for a long time. I think we
Yes,
will have
sir.
to reschedule one more class.
Sir, okay.
Ma'am, what is your opinion? I think it will require a thorough discussion, no?
Yeah, sure. If they're interested, why not?
Yeah. Okay, I think we will stop the class for today. We will reschedule one more class for all this.
I think Samir
Mm,
presented very well.
Yeah. Thank you, ma'am.
Mhm.
Any other inputs you want to give, ma'am, till now?
No, I think he's done well,
Nothing.
quite. Yeah,
Okay.
nothing.
Okay. Sanya, your comments. Sanya, Karthik, Nikita.
Very well presented, sir.
Yes. Karthik, Nikita, because I was not there in the first half.
No, sir. He covered anatomy also very well, sir.
Okay.
With all the diagrammatic representation, he did well.
Including the
Okay.
physiology part, it was very good.
Okay.
Yes.
Samir, then well done. Okay, we'll reschedule the class for another day for the rest of the topics. Yeah.
Okay.
Thank you,
Sure.
ma'am. Thank
Thank,
you. Thank
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 you
you,
you.
ma'am.
for inviting me. Thank you, Samir.
Thank you.
Thank you, everyone. Bye.
Thank you, ma'am.
Thank you.